Now joining Kathleen, please welcome our panel of Medicare experts. Julia Schreiber, Program Director at the Maryland Department of Aging and Administrator of the Maryland State Health Insurance Assistance Program. John Blum, Non-Resident Senior Scholar at the USC Schaeffer Institute and former Principal Deputy Administrator and COO at CMS. Kristi Martin, Director of Healthcare at Camber Collective, a mission-driven consulting firm, and former Senior Advisor and Chief of Staff at CMS, and Dr. Phillip Duncan, an Associate Professor at Virginia Commonwealth University School of Medicine and member of the Association of Black Cardiologists. Welcome all.
So, good morning, everyone. Thank you for joining us. I'm going to start by going down the line. I'd like to know what each of you, so we're looking at Medicare open enrollment during this period, and the changes that are hitting us in 2026. What stands out the most to you, and how is 2026 different from previous years? I'll start with you, Kristi.
So I'm from the State Health Insurance Assistance Program, and we offer free, unbiased counseling to Medicare beneficiaries, their loved ones, and caregivers. I'm actually going to touch on a change for 2026 that's a little bit unique. For those that are considering Medicare Advantage plans that also provide prescription drug coverage, when searching on the Medicare Plan Finder, it now has provider directories. So beneficiaries will be able to search based on the providers that they actually see. And this is a big new development. Inevitably, there are going to be quirks that need to be sorted out. So CMS is offering a temporary special enrollment period in 2026 in case a beneficiary makes a decision based on information that was inaccurate or incomplete from these new provider directories.
So Julia, that goes how far into 2026?
It's for the full year, but right now it's just for 2026. There's a temporary special enrollment period. So I advise this year in particular, document. If you're searching on the Plan Finder, maybe save some of those details, print them out in case you need to access that special enrollment period next year.
John?
I think in some respects, this year is not dissimilar from other years, thinking about the Medicare program. The Medicare program has had choices as part of its kind of overall structure going back into the 1980s. Those choices are more plentiful today than they were back then, obviously, but I think this is really a time where all Medicare beneficiaries, their family members, their advocates should take time to think about what coverage options are best suited for their own circumstances. I think the one thing that Medicare beneficiaries really need to think about is that healthcare needs change over time. And so the plan you're in today might not be the best plan for the future. And so I think that's really what beneficiaries need to think about, what their needs are today, what their needs are going forward. And particularly in the Part D benefit that I'm sure Kristi will talk about, is that benefit now is designed for those that have higher needs, catastrophic needs, cancer diagnosis. And I think this time element gets kind of underplayed during the kind of open season messaging. But beneficiaries' needs change over time. That's part of life, and taking that into account, both the current needs but also your future needs, is really, really important. And some beneficiaries might be better off staying with traditional Medicare and thinking about standalone Part D drug coverage. So this time element really needs to be factored in, and those that counsel beneficiaries need to ask that question: how do you think about your benefits today, but how might you need to think about them, say, in 6 months, 12 months, or even 5 years?
Kristi, what should we pay attention to?
Yeah, and I don't mean to be a Debbie Downer, so I'll start there. But with some of the staffing changes that have happened over this last year at CMS in particular, unfortunately, we've lost some really important people in the Office of Communications and some of the people that have helped train the brokers and agents and the SHIP counselors that help us get ready for open enrollment every year. And so this year, more than any other year, I think the SHIPs are vital for people to help make those choices. So I'd encourage people to reach out to shiphelp.org, reach out to their state health insurance assistance programs to get that help and make sure that they're picking the right plan for for them this year. Plans change every year. People's needs change every year. Along with that, there's the extra help program that can help defray the cost of Part D premiums and out-of-pocket costs in the Part D program. Eligibility in terms of like what income level and limited resources that could make you eligible for that program shift every year with, the differences in, how much we have inflation changing. So you could be eligible this year and weren't eligible last year. So check to see if you're eligible for those types of programs. The Medicare Savings Program, the SHIP counselors can help you with that as well. So that's really important. And I think, also we've been talking about the Inflation Reduction Act this year. The maximum out-of-pocket limit for the Part D plans is $2,100, which is still incredible to even have a maximum out-of-pocket cap in the Part D program and in the Medicare program. So I would highlight those changes and then, again, just reiterate making sure to go to the SHIPs and asking for that help because it's really important.
Phillip, as a doctor, what stands out to you?
So when I look at the changes coming, I think that for those who are savvy, who have access to the internet, and I think there are opportunities for them to choose the correct plan.
But that doesn't describe everyone.
Exactly, and the concern that we have is one, health changes quickly. So your situation on November 1st may be very different on March 1st. And so a plan that looks great on November 1st might not be the plan for you on March 1st. And in the Medicare age group, of which I'm a member, you can't, those things can come even more rapidly. So I look at this and I say that, each year we make these changes and we tweak things around, around the edges. But in the end, we have to have some kind of substantive change that recognizes that health is an important non-renewable resource that everybody deserves. And so I'm hopeful that these small changes will get us moving, but I recognize that we need larger system-wide changes and approaches to how we deal with healthcare drug benefits.
Julia, what are callers, when they're calling into the SHIPs, what are they asking about most? Is it this reduction in the number of the Part D plans? And if so, what do you think are the ramifications of that?
So we are getting, the majority of the questions that we get are the right questions. So are my medications are going to be covered? Are they on the formulary? How much am I going to be paying at the pharmacy counter? Are there coverage restrictions? So I highly encourage asking these questions. We have absolutely seen an influx of calls around people asking, what are they going to do? What do I need to do? I got this termination notice. My plan is not renewing next year, so I have to select another one. As SHIP counselors, we do our best to find an alternative. But I will say that in Maryland, and I believe this is a trend across the nation, and I'm hearing from my peers in other states as well, we have gone from 10 Part D, last year we had 14 Part D plans, and in 2026 we'll have 10 Part D plans. And then for Medicare Advantage with prescription drug coverage, we've seen geographic consolidation. So longstanding plans that were offered maybe across the state are now solely in certain areas. So the options are they're still there, and beneficiaries should be considering them, as has been said, every year. But as that choice diminishes, it can create some real challenges.
I'm curious what your SHIP advisors, when people call in, what are they telling folks when they say, hey, is my drug on the formulary if the formulary list isn't out yet?
So there's information currently in there, so they can make the best decision that they can with what's there. One thing that we note is that during this particular open enrollment period, that if you make a decision and enroll in a plan now, you actually can switch plans as many times as you need to within this Medicare open enrollment period. So that's not an ideal situation, but say you enroll in something now, you do have the option. Now for the Medicare Advantage open enrollment period, January 1st to March 31st, for those that have Medicare Advantage, you can only make one change during that period. But now there's a little bit more flexibility.
So if you, I mean, open enrollment started, I guess, a couple weeks ago, right? So if you already made a decision and then you realize you've made a bad decision, you can change it before, what is December 7th?
December 7th, yep.
Okay, fascinating. John, what are your thoughts on the future of Medicare Part D drug plans? I mean, the way things are looking, the future is not bright, but I understand, we have, obviously this year, as Julia explained and Kirsten also, we have fewer choices than ever before, but I understand you say that's the beneficiaries want fewer choices, and that sounds a little counterintuitive to me.
I think it's a real important question of kind of how much competition we need within the Part D program in order to get the best value, to get the best experience for beneficiaries. I don't necessarily believe that the number of Part D plans is the right number for us to focus on, but is there sufficient choice? Do we have competition? And what I heard during my time from serving as CMS from the SHIP counselors is there's too many choices. And beneficiaries really struggle with how to evaluate 15, 14, 25 different Part D plans that's being offered to them. I think one of the questions for the future should be, what is the right number? How much competition do we need in order to get the best value? What's the right experience that we want to offer to beneficiaries? And I think what I heard during my time at CMS is that beneficiaries want choices, but they want to be able to feel confident they're making the right choice. And so I think that should be the metric of, do beneficiaries feel they're getting value? Do beneficiaries feel they're confident making choices? And that to me is the ultimate metric, not do we have 10, 14, 25 different Part D plans, but the metric is, do beneficiaries find value? Do they feel confident they're making the right choice? And what I heard during my time at CMS is there is more choice than any one person can sometimes handle, and that's a concern that we should be worried about.
Kristi, you played a central role in implementing the Medicare drug price and negotiation program. Are the results that we're seeing what you expected and what you hoped for? And if not, then what needs to change?
Yeah, I think with any program, especially a new program in the federal government, there's always some anticipated changes you would like to make over time. And especially with this program, we implemented it, I think, in record time. We were given a very tight timeline, but overall, I'm very proud of the work that the CMS team did. I think they did a phenomenal job, and it was a true negotiation. And I think if you asked, and if you looked at the shareholder reports that came out, the shareholder calls that were done, a lot of the statements by the CEOs and the media reports afterwards, they gave very positive statements about how the process went. And overall, we did get very good prices. The Medicare Part D market is an interesting market. The prices that the Medicare Part D market had before were not the same as the commercial market because of some of the financial incentives that were in the Part D market. It's not the same as other private health insurance. And so I think that, over time, the team will get more sophisticated in their negotiation. I think the second round, they will outperform the first round because they've learned over time that nature of the drugs that they're negotiating right now is a very different set of drugs. So, I think that there will be tweaks over time like any federal program. But overall, I think they've done a stellar job, and I think they will continue. And ultimately, if you have to look at the Inflation Reduction Act and the Medicare provisions as a package. The point of the negotiation program was to generate savings to enrich the benefits of Medicare. And that was the out-of-pocket cap, the $35 insulin monthly cap, the no-cost vaccines that were delivered, the other pieces of the puzzle that actually delivered the enriched benefits to the beneficiaries, expanding the extra help program. Those things we're extraordinarily proud of. as well as the negotiation program.
Phillip, as a doctor, I'm curious. So you've been a cardiologist in nearby Richmond, Virginia, for decades, right? So how have you seen these high out-of-pocket drug costs impact your Medicare patients specifically? And are you seeing any improvements in recent years as these changes that we've been discussing are going into effect?
So high out-of-pocket cost is unfortunately, it's a travesty because we have so many wonderful therapies available to patients. And these therapies continue to improve, and we get new meds and better outcomes with various conditions like heart failure or the new meds that we treat patients with, for example, atrial fibrillation. The issue is that while things can be done on a programmatic basis, things can be done in terms of looking at more choices, medicine is actually very personal. And so for some of the patients that we see, a $45 copay is just as significant as a $500 copay. At the end of the day,
so 45 may as well be 1,000.
Exactly.
Wow.
You know, so when we look at that, we have to rethink how do we look at healthcare and understand that there are things that can be done on the macro basis, but it's personal. It's about, you know, relationships and those things that improve our health. And if you look at our health statistics in the country, and you look at our life expectancy actually plateauing and maybe falling for various reasons, including COVID and drug epidemics, but you look at that and you say, okay, if you're not getting the results that you want for us as a group, we need to look and say, okay, how do we readjust this, refigure this so that we see that improve?
And as a cardiologist, when your patients don't take their meds, the results are pretty serious.
Right.
Well, what do you see?
Well, what happens is patients might have a copay that doesn't allow them to take a medication for a certain period of time. So, for example, someone has a heart attack, if they get stents, there's a certain set of drugs that they need to take for up to a year that if they miss it, they may have another heart attack and come back. Patients with, like I say, atrial fibrillation, abnormal rhythms, there are drugs that they can take that if they don't take them, they can have a stroke. And that's personal. And when cost is the only barrier to that's a travesty.
Julie, when people are calling in to the ship lines, what are the biggest challenges that your team members are facing in helping them?
I would say, generally speaking, it is it's complexity and misinformation. So when making these decisions each year are not simple. You got formularies and tiering and coverage phases, and these are all technical things that you need to have a strong grasp of in order to make an informed decision. So one of the challenges is putting this information about health insurance into plain language so that beneficiaries are empowered to make the decisions themselves. The other is, we are all, and beneficiaries in particular, are bombarded with marketing and selling of certain plans, and which often highlight exciting benefits, so a benefit card or a gym membership, but they don't necessarily speak to the trade-offs. So working closely with beneficiary to understand what their needs are and really paint the full picture for them so that they can see where their priorities are and make a decision based on the full picture of information.
John, I was wondering, how can CMS better anticipate and respond to some of these unintended consequences that we're seeing, these, because we have these improvements that were meant to reduce seniors' out-of-pocket Medicare costs, and it's not always happening. So I guess what I'm wondering is, do they need to take action, and can they, and rein in things like some of these utilization, management practices, like pre-authorization or step policy that end up limiting access to needed medication?
I think one of the points that Kristi touched upon is just the staff changes that have happened to CMS. And I think in the last several months that staff is down by about 1,000 people. That's roughly 15% of the overall agency. And overseeing the Part D plans, my experience is that it's a real contact sport. You can't do it through technology. You can't do it through computers. You really need to be talking to health plan CEOs directly. You need to be overseeing the Part D plans to make sure benefits are being delivered consistent with the law, consistent with the regulations, consistent with our values. And I think we are at a real challenging period. And there is change happening to the Part D program, and that's intended because the Congress really wanted to see changes to the Part D program. But we don't have the infrastructure right now in place to really make sure those benefits get delivered well, get communicated well. I think we really have to have a conversation together regarding what is the right staffing needs that we need at CMS. I would argue strongly that's far too low right now, and that's going to have impact throughout the country. And so the oversight, the management, the delivery of benefits are things that need to be done by human beings. And that's something that is not currently in place that needs to change going forward to ensure that we can deliver the value to the Part D program as intended by the Congress.
Kristi, I was wondering, does CMS need to do anything, and can it do anything to support these independent pharmacies? I know that Adina talked about it. I discussed this also with Kirsten. When they have these cost burdens that you know, it has some of them, what I think it's, according to the National Community Pharmacists Association, more than 93% saying we aren't going to cover one of those drugs that you negotiated the prices for. We can't afford it.
Yeah, so taking a step back a little bit, especially with the pharmacy issues, you know, the pharmacies have been experiencing issues for several years. I mean,
I misspoke. They aren't going to carry. I didn't mean to say cover. They aren't going to carry these drugs.
They've been facing issues for several years, especially the community pharmacies, the smaller pharmacies, the independent pharmacies. This is not just the Inflation Reduction Act. This is long before the Inflation Reduction Act. I think COVID in particular exposed some of their financial issues and the struggles they were having specifically with the pharmacy benefit managers and the plans under reimbursing them, and with some of the issues they were having with the supply chain and the wholesalers and how their supply chains were being set up. And then, you know, then we had started having some issues with that they were raising around the Inflation Reduction Act as well. But it's not just the Inflation Reduction Act. And, you know, CMS is very sympathetic to their issues. I think a couple of points to make. One, under the Part D program, there is the non-interference clause. That does extend to the interactions between the pharmacies and the Part D plans.
Can you explain that, what this is, non-interference clause?
So whenever Congress passed the Part D program, and authorized the Part D program, there's a non-interference clause that was built into it. That non-interference clause is most of the time interpreted as CMS cannot interfere with the negotiations between pharmaceutical companies and the Part D plan sponsors. It also means CMS cannot interfere with negotiations between the pharmacies and the Part D plans, meaning what the rates that they're going to be negotiating for dispensing fees, what rates they're going to be negotiating for reimbursements, and how they're going to be building out their networks other than we set network standards. And so that creates some issues with how does CMS get involved and what is the authority for CMS to get involved and what those reimbursements are and how CMS helps to set those rates. We do not set those rates. And so that's always been an ongoing issue. And so then when it came time for the Inflation Reduction Act and when we negotiated the maximum fair prices or the negotiated prices on the 10 drugs, you know, we started working on a process for how does that flow through the supply chain ultimately to the pharmacies. And we set up a process so that we could help the pharmacies make sure that they were made whole in the end. It helped to facilitate that process. And, you know, ultimately, in theory, the operations will work. It hasn't started yet. It starts January 1st. And I think we'll see how it works out. But one of the issues that I want to also raise is that, and I think the doctor, you know, acknowledged this pretty well, it's not just about these 10 drugs. Most Medicare beneficiaries are not just on one drug. most take 4 or more prescriptions because they usually have very complicated or complex health issues. They just don't have one diagnosis. They usually have more than one. And sometimes they have pretty complicated health needs that they're trying to address. So if a pharmacy doesn't carry one drug, they also may lose a customer that is also picking up 4, 5, 6, 7 prescriptions from them. So I think pharmacies really have to think about, are they at risk for losing a customer that's actually going to be bringing them more business than just that one drug? So the economics of it are a little bit more complicated than just not carrying one drug. It's about how do they think about delivering for their customer and their constituent that they're serving, not just, we're not going to carry one drug out of the 10 that have been negotiated so far.
It really gets complicated.
It gets very complicated, and I think the pharmacies, do have a lot to think through as they go through this process. And CMS has been having monthly calls with the pharmacies to try to help them through and help them to think through this, and they've been working with them on the operations on how to ensure that they are getting made whole financially through the process of the negotiation program.
Phillip, I was wondering, how often in your office does your staff have to intervene to find more affordable, more cost-effective alternative medications for your patients? Or how often do they have to refer them to patient assistance programs, or do you have to prescribe proactively? Do you base what you prescribe for your patients on their financial means? And then how does that impact outcomes?
So that's, currently I'm in more academic practice, spending more time in hospitalized patients, but a long history of working in the office. And that's a daily chore with multiple patients, finding out what they have, what they can afford. And on the hospital side, when we have a patient in the hospital, we will do a price check on medications before we discharge patients with a certain pathway, certain prescriptive pathway, which means sometimes we give people less than the best. Sometimes we cannot afford to, or the patient cannot afford to take on those medications that would be in their best interest. And then the other part of that is, yes, there are programs, there are ways where we can sometimes get support for these, but often that's time consuming. It takes time away from staff that could be doing other things that's more patient leaning. It's often complicated for the patients. I have patients who live out in rural areas where they don't have any internet access. They don't have access to the computer. Whatever they do is usually done when they come to the doctor's office and when they interact with that office, and it's what they can do for them. And if their resources are stretched, then it doesn't get done. Patients don't get what they need. And there's one other piece to that too, because what we have now is a system where we have a drug plan, you have a physician, a provider, you have a pharmacy. Now, for the patient who's at the center of this, there may be trust in that pharmacy because that's where they went to and that's where they get their medications. There may be trust in that provider, but their drug plan might be covered in a plan that doesn't include these folks over there. And that's a challenge. We forget, again, that personal trust factor that's so important to effective medicine.
But to go back to the prior point you were making, how frustrating is it when you are basing your decisions, your medical decisions, on what people can afford and not what they need?
It's extremely frustrating, particularly when you have a patient who may have done well on a particular regimen for a period of time, and they have done well, and then you have to say, oop, January 1, we've got to switch this, or we're going to take you off this and see what happens. It's exceedingly frustrating because we're not offering the best for our patients when we do that.
Julia, what strategies are SHIPs following to help them to help the people who most need help when it comes to beneficiaries, specifically those who are lower income or in areas where it's just tougher to find the services that they need of all sorts?
So I would say, broadly speaking, one of the benefits of SHIP is, at least in Maryland, is that services are delivered locally. So really meeting people where they are. offering counseling sessions in senior centers, in retirement communities, in libraries. The other thing that I would say is, well, one, there's significant under-enrollment in extra help, so the Part D low-income subsidy and the Medicare Savings Program. So many people that are eligible but are not enrolled. So really trying to raise awareness for that especially during open enrollment. We screen everybody that we see to see if they are eligible for those, even if they don't ask about it. And then also helping people get creative. So when we talk about what options, considering options, we're talking about plans and what choices we have there, but also there's additional programs like prescription drug assistance, we have the Senior Prescription Drug Assistance Program, so for those that don't qualify for extra help. We have some pharmacies. We have a new nonprofit pharmacy that redistributes surplus medications called Good Pill. They're only certified in Maryland, but it's $2 for a 30-day prescription. So there's some, that's unique to Maryland, but trying to connect people with some of these other programs that exist to help them afford their medications.
John, you've written extensively about your vision for rebuilding CMS, the Center for Medicare and Medicaid Services. So what structural reforms do you think that CMS needs to make to ensure, that these changes that we're discussing today, that they better serve all beneficiaries?
I think one of the trends for all three programs that CMS oversees, Medicare, Medicaid, but also private insurance, those programs have been structured by Congress, by law, to really offer choices. And so beneficiaries, whether you're part of the Medicare program, you're part of the Medicaid program more and more, whether you're getting your coverage through the exchanges, you're going to have to think about which plan is best suited for you. I think the skill set for the future for CMS will be more and more to help beneficiaries make those choices, oversee competition to ensure that it's rigorous. Think about mechanisms like risk adjustment and quality ratings that really build strong incentives for better beneficiary value. I think particularly in the Medicare program that it was built and it was staffed to run the traditional Medicare programs, setting fee schedules and setting all the payment levels that are part of traditional Medicare. That's still important, but I think we have chosen as a country, we can debate whether it's good or bad, but it is a choice that we have made to deliver more of our CMS-run benefits, Medicare, Medicaid, and private insurance through competing private plans. And that is a skill set that we're going to have to continue to develop. We're going to have to continue to staff for that oversight, making sure the payment is right, making sure the value is good, making sure we have strong incentives towards caring for the sick, but also to provide best-in-class customer value. And that's a skill set that CMS has today that will need even more going forward.
Kristi, what cautionary lessons for the future can we draw from the healthcare industry's response to these changes to Medicare for 2026?
So I think a couple of things. I think that, we're seeing a lot of things this year in response to, there's a lot of short-term thinking. I think a lot of knee-jerk reactions to some of the issues that are going on. There's a lot of volatility in the healthcare space right now. I think some of the premium reactions are, concerns about what is happening. And so they're worried about things are going to change. And so they're increasing premiums, thinking things are going to change, and they're not sure what's going to happen. So they're reacting to that because they're not sure. And I think the other thing that we can learn too is that we need to just be having conversations about what to expect and what's going on. I think when John and I were at CMS, we made a very deliberate effort to have an open door policy. So anybody that asked us for meetings, we had meetings with them. We were very clear about we wanted to talk to stakeholders. We wanted it to be a two-way dialogue. I think the other thing is we also had a stakeholder engagement plan so that we had regular town hall sessions, we had regular stakeholder calls. We provided opportunities to make sure we were telling people, here's where we're going, here's what we're doing. I think every center had a strategic vision that they put out there very early. I know my boss, Dr. Meena Seshamani, had hers out there within 3 months after I came on board in October of 2021. But every center lead had their strategic vision about here's what I'm doing, and it all followed from John and Administrator Brooks LaSure's strategic vision. And so really like setting out a roadmap so people knew what was happening and trying to create that predictability. And so I think in 2026, that's what people are really lacking, and that's what we need to try to get to, is giving everybody an opportunity to say, here's what's going to happen, and like let's try to create some dialogue, but also some certainty for the future.
Phillip, I'm going to give you the last word. I'd love for you to give us a message. What, as a doctor, do you want to tell policymakers about Medicare Part D or the Medicare system in general? What would that message be to them?
Medicare Part D, Medicare, I would say that we deserve good health care for everyone. And right now we have an issue where health care is the sun. Many people enjoy the sunshine of good health care and access, but there are people who live in the shadows. And so we need to bring this to high noon so that everybody gets the benefit of the outstanding health care we have available to us in the U.S., but is totally affordable or unavailable to a segment of our population.
Wow. Everyone, please join me in thanking Phillip, Kristi, John, Julia for your wonderful insights today. We really appreciate it. As I said, this is a complicated issue. We didn't cover everything, but we did the best we could. So it's time for the event to wrap up. But thank you all. Thank you all for joining us here in the room and those folks watching at home. I hope we answered some of your questions. And a big, big thank you goes out to our sponsor, the Alliance for Aging Research. Thank you for making this possible. Now, if you happen to miss this, or you have friends at home who go, oh gosh, darn, I wish I'd seen that. It's all going to be available online, and that will be at thehill.com. So the full video will be there. Well, thank you all. Thank you for joining us. And for those out there making those Medicare choices during open enrollment, good luck. I hope we helped you. So thank you all, and have a great day.